if we talk about the non-selective beta blocker, so non-selective beta blocker means it is going to block both beta 1 as well as beta 2 receptors. But if we talk about cardioselective beta blockers, that means they are going to primarily block beta 1 receptors. Now, if we talk about specifically beta 2, so specifically beta 2 does not have any antagonist, okay? Where was beta 2 present? Who remember? Anybody remembers where was beta 2 present? Location, this is very important.
So beta 2 blood vessels, no, now the alpha 2. Now beta 2 the blood vessels.
So there is no such beta 2 antagonist present, okay? Now, over here, if we talk about the blocking a sympathetic receptor, okay, so that means what? So if you are talking about like there are suppose intrinsic sympathomimetic activity going on, okay, so intrinsic sympathomimetic activity means if it is mimicking the sympathetic activity. So if you are going to, like in case of CNS, central nervous system, there can be block of the sympathetic receptors. Can we say this way, that there can be block of sympathetic receptors?
Yes, sir.
Yes. So if there is block of sympathetic receptor, then what do you think? Vasoconstriction will take place or vasodilation will take place?
Vasodilation.
Yes. So there can be vasodilation taking place. Now, next thing is that if you are having beta blocker, so beta blocker will definitely, it is blocking the beta receptor. So BP is going to decrease.
Reduce.
So if you are lowering the BP, so I think now these things are getting easy to you, na? That you know what is happening where, because you know the receptors and you know the function. So if BP is getting low, that means this is a good drug for hypertension. If a patient is suffering from hypertension, so this is a good drug for it, lowering the BP.
Yes.
Because see, since this is a beta blocker, so this is going to work only on beta 1 and there is no such selective beta 2. So it is going to work, it is going to lower the blood pressure, but imagine if it would have worked on both alpha as well as beta, then do you realize even your blood vessels would have got dilated immediately? Hai na?
Yes, sir.
Then there would have been a tendency of postural hypotension. You are lying down and then suddenly you stand up, you faint, you undergo syncope. So that is called as postural hypotension. Na? You change your posture and you develop a hypotension. So
Yes, sir.
in these kinds of medicines, that is not going to happen. So this is more of a good drug. That's what I'm trying to say. Because the adrenoceptors, they are normally working, so there is no chance of postural hypotension. And hence the other places other than the heart, as far as the vasculature are concerned, they will remain normal. They will remain as it is. There will be no change in that. So beta blocker can be used for all the cardiac problems. Like I think you know about the general cardiac problems like congestive heart failure. Do you know what is myocardial infarction? MI? MI is myocardial infarction.
Heart attack.
Yes, very good. It's a heart attack. Basically, some of the myocardial tissues are dead. So, or like ischemic. There is a word that is called as ischemia. Okay, I'll just. Do you know the difference between myocardial infarction and what do they say? That angina. There is another word written. You see, that's called as angina pectoris. Do you know the difference between the two?
No, sir.
No. Look, if I say that there is present a condition called as IHD. What is IHD? It is basically ischemic heart disease. The word is ischemia or ischemia. So what does it mean? That whenever any part of your body is not receiving good amount of blood, so that is called as ischemia. Just like any part of your body which do not get oxygen, hypoxia. Same way, any part of your body which do not get blood, that is ischemia. Now over here, suppose I'm not very good at artwork. I'm just trying to show you a point. Uh, Pardon this adbhut artwork. Is it understandable at all what I'm trying to make?
Yes, sir.
Yes, sir.
Oh, really?
হ্যাঁ স্যার
Acha.
স্যার ম্যাঙ্গো যাচ্ছে মনে হয়
Mango. Acha. Anyways, chalo. From this mango, you made it out that this is a heart also. So, do you understand where are we up to? Ye dil, mango, more.
হ্যাঁ
So, okay, this is like this part is the superior vena cava, this is the inferior vena cava. I hope you are understanding. Aorta,
Yes, sir.
pulmonary artery, and this is going to be your right atrium, and this is the right ventricle, and then on the behind the screen there is present the left ventricle. So uh, over here there is present, now I'm going to talk about a vessel. This I'll talk about a blood vessel. So you will see that there is present a very cute kind of a beautiful blood vessel. It comes out from the aorta, so like this. I'm not going very accurate. These are going to supply the myocardium. So this is going to come down. It has its own anatomy. We will discuss someday later, since we are discussing drugs. This is not going to be a part of it. So it will go around circumflex. It will go backside. This is the coronary artery. So what happens is, like if you look at a little bit of this coronary artery, suppose I'm going to zoom over here. So if you look at the coronary artery here, so let's say this is that section of the coronary artery. So what happens over here is, this is a long story. When we will discuss cardio, that time we are going to discuss it in detail. For the time being, just we will go a little bit brief. So what happens is, suppose there is a patient who is eating lot of egg rolls and cutlets and those stuff. So what happens that here some excess amount of lipid deposition takes place inside the vessel, okay, in the connective tissue portion. So if it is present like this, do you know that blood vessels have got layers like intima, media, and externa or adventitia?
Yes, sir.
So if that happens, do you believe that the intima layer is going to go like this?
Yes, sir.
Flow of the blood will be disrupted, platelets will get activated. If platelets gets activated, you know what happens, they are going to form aggregate, platelet aggregation will take place. If platelet aggregation takes place, then there can be some fibrin meshwork forming on top of it. These are normal processes. Whenever there will be platelet aggregation, after that coagulation takes place, clotting.
Yes, sir.
Do you see? Yes. So do you see that this blood vessel is getting blocked? So this deposit which forms over here, the entire deposit, this has got a name. It is called as atheroma, and this condition is called as atherosclerosis. The plaque, the deposit, is called as atheroma, and we will say that the patient is developing atherosclerosis, suffering from atherosclerosis. Now imagine if this part is getting blocked. Do you realize that this portion is not receiving any blood at all?
Yes, sir.
Yes. Now depending on situation, it can be mild, that means things have just started happening. So if it is mild, then the patient will develop some pain in the chest and mild ischemia. So this part is getting ischemic. So mild ischemia, patient will develop pain. So as doctors, you should be very thorough about it, that this pain is not really a lancinating pain or a sharp pain. It is not a pain of that kind. In my experience, I have come across a few cases where my nearby relatives and all, they call up at night hours, and then they start saying that I'm having chest pain and all those stuff. So there is one thing which helps me understand that whether it is a matter of immediate concern or not. So that is the type of pain. So you ask the patient that, where are you facing the pain? Where is the pain? So the patient will tell that, I'm having the pain in the middle of the chest, I'm having pain in the left side of the chest. Mainly patients tell it in the left side of the chest. So because patients are also semi doctors, so they consider themselves to be like 200% doctors, but actually they are very much illiterate. But anyways, so they will think that heart is on the left side, and we doctors know that heart is definitely not on the left side. It is located centrally, it is just tilted towards the left, that's it. But anyway, so the thing is this, patients get too much concerned when their pain starts happening on the left hand side. Now there are two things. There is a very immediate differential diagnosis that comes up. What is the differential diagnosis? Means when you have got 2-3 diagnoses and you have to differentiate one from the other. You will learn all these things in higher classes when you will be learning about general medicine over there. So for the time being, just trust me that there is, out of many differential diagnoses, the common one that comes up, that is heartburn. Heartburn has nothing to do with somebody gave dhoka and somebody dil jal gaya, heart is on fire. I think there is an emoji also like that where the heart is on fire, but it is not like that. Heartburn is basically a
Another determined determination.
हाँ, तो basically, if we talk about the heartburn, its other name is pyrosis, and it is because of the gastric eructation. The gastric acid it goes up to the esophagus, causes excoriation. You feel the pain. So when a patient tells that I am having pain on the left side of the chest, you should be very, very relaxed. If the patient says I am having pain on the center of the chest, you should be feeling very relaxed. If the patient says I am having pain on the right side of the chest, you should be relaxed. These are not angina, because anginal pain cannot be pinpointed, because it's coming from a visceral organ, na? So how can a person pinpoint that pain? Because you should know one thing: visceral organs do not have pain receptors. They are all under autonomic nervous system control, and for pain reception you need peripheral nervous system. I hope this basics you know from your last year physiology classes. है ना?
Yes, sir.
Yes. So over here, remember this, कि if we talk about these pain sensations, so you cannot get it from the heart. So what is the usual complaint of the patient? The usual complaint of the patient is कि I am having pain, and when you say where is the pain, they will say that it's on the left, it's on the right, it's in the middle. I cannot say where the pain is, but it is coming like it's a pain coming from the chest area. Now you should worry. Huh?
Referred pen type of.
Exactly. Now you should be worried. Now you should get worried that this is angina, because anginal pain doesn't come like a real pain. Anginal pain comes like a discomfort. Anginal pain is more like if you tell the patient that is it like compressing your chest? Patient will say yes. Many times patient tells himself or herself that as if somebody has put a stone on my chest. I'm feeling very heavy. My chest is feeling very heavy. If you ask them that is it worsening when you are walking or when you are climbing stairs, or if you are walking against the wind, they will say yes. So you should get worried about these pains. These pains are dangerous. That means it is a case of angina happening. Sometimes anginal pain is very much misguiding actually. It can misguide a lot basically. Sometimes patient come up with a toothache. Okay, pain in the tooth. But when they come up with pain in the tooth and you look at the tooth, you find that no problem. Gum is healthy, tooth is healthy, and you start getting confused. So you should not get confused. You should also keep a check on the cardiac condition. Okay, because anginal pain can be referred to left arm, it can be referred to the jaw, it can be referred to the teeth, to the head. Okay, so dental pain or mental pain means headache. Okay, so both can happen. So it refers it the patient will develop a lot of referred pain. So you have to, that is why learning the general medicine and these general health issues are very important. You cannot remain confined within those your 32 teeth. So you have to know about these things also if you want to become a very good dental surgeon. Otherwise you will become just a dental surgeon. So remember that if it is mild, you should immediately ask the patient that okay, you should start taking glycerin trinitrate. Okay, we will discuss all these things in the cardiac chapter. Glycerin trinitrate is going to act as a vasodilator, and immediately the patient might feel relieved. So okay, so these things can happen. Now what if it is severe? Severe means this condition was happening for a very long time and patient has been neglecting it, and over this period of time, slowly and slowly and slowly and slowly and slowly, the tissue died. Understood? And when that happens, we call that as myocardial infarction. Infarct you will learn, I think you have or you will learn this year in pathological classes, and infarct means dead. So there can be a kidney infarct also. Infarct can take place in any part of the body. Here, since the infarction or infarct is happening at the myocardium level, hence we call it as the myocardial infarction or MI. Understand? So yes, so in case of myocardial infarction, what happens is, why are we giving these kinds of drug then? Like, what will beta do in case of myocardial infarction? Because normally what do we do if a patient of heart attack or myocardial infarction, severe ischemic heart disease comes up? Our first step is use some clot buster, anticoagulants. Okay, if you see anybody in your home, family, friends, relatives, enemies, anybody, mainly elderly person, mainly males. Okay, so if you see any elderly male person who is taking aspirin, like nowadays the commonest tablet is Ecosprin, so gastric resistant tablet. So if you see a person taking that, so you should understand that that person has got a tendency of developing a heart attack. So aspirin acts as an anticoagulant. It prevents platelet aggregation. Okay, we will discuss it when we will discuss hematological drugs. For the time being, just trust me that aspirin actually, from layman language, they say that this is a blood thinner. So blood becomes thin so that it doesn't clot, but you as a doctor should not go by that. You should know that it is a anti-platelet drug, so it prevents the aggregation of platelet, aspirin. So if there is no platelet aggregation, then there will be no blood clotting. So this is the main basic idea. So if we talk about this process, okay, so over here we are going to use some antiplatelet agent, then we are going to go for some angiography. We will check where the block is, we will inject some dye and check where the block is. Then we can go for angioplasty. Either we can go for a balloon catheter with apply some stent over there. You will learn all these things later on, or maybe you know already. Or we can go for the cabbage procedure, cabbage bypass, coronary artery bypass graft. So we can go for that procedure. So there is a different line of treatment. But then why beta blocker? What is beta blocker doing over here in ischemic heart disease condition? So remember, if your heart is not receiving blood, if your heart is not receiving oxygen, but your heart is still living, like the patient is alive, that is when the patient has come up to you. Dead patient cannot walk to you. So the patient is alive, that means the heart is still beating. Now if the heart is beating and there is no oxygen, no blood, do you realize that work done by the heart is getting even more oxygen? Whatever, like little amount of oxygen in the heart is getting, And if the heart is working more, then the person's muscles will be destroyed even faster. The lifespan of the patient will deteriorate. Are you understanding my point?
Yes,
Yes.
sir.
Yes. So this is the moment we have to, like, till the time we actually do some definitive treatment on the patient, we have to make the heart relax a little bit, so that the heart muscles, whatever damage has taken place, that damage remain restricted, and the damage doesn't increase or the damage doesn't spread. So okay, so for this purpose, in case of angina, in case of myocardial infarction, okay, even in case of congestive heart failure. What is congestive heart failure? Do you know that congestive heart failure? Congestive heart failure is, like, suppose okay, if I say, suppose this is your left atrium, this is your left ventricle, this is the aorta, and let's suppose this is your right atrium. Okay, I'll imagine this is your right atrium, this is your right ventricle,
স্যার
and
ওই
this.
তো বলেছিলেন কনজেশন হয় আর্টেরিয়াল চেম্বারে পাম্প করতে না পারার জন্য, তাই জন্য
Acha, we discussed that previously. That's great.
Yes.
So you see that if this right heart is failing, so that means heart failure is taking place. So that means the blood which is present over here, that will remain over here only. So if this blood cannot be pumped, then can that blood reach the left atrium? No, right? So it will remain congested in this area. So that is, and if left ventricle doesn't receive any blood, what will it pump? So this is the reason why there will be heart failure. So this is called as a congestive heart failure, CHF. Now, even not only this, hyperthyroidism, because hyperthyroidism increases the metabolic activity, heart rate is high. In case of patients who have got hyperthyroidism, okay, you will see that their heart rate is always high. So in all these cases, we can make the heart relax, okay, by in case of glaucoma also. Okay, in all these cases we can make the heart relax by giving them this beta blockers. Okay, is that understandable?
হ্যাঁ স্যার।
হ্যাঁ স্যার।
Do you know what is, by the way, has sir is fine, but do you know what is glaucoma?
ওই তো স্যার ওই কি বলে, মানে ভিতরে যে অ্যাকোয়াস হিউমারটা আছে ওটাকে মানে বেরোতে না পারে আর কি, ওটা ইয়েটা যাচ্ছে মানে শুকিয়ে যায় আর কি ব্যাপারটা, মানে
শুকিয়ে
মানে অ্যাকোয়াস হিউমারটা চেঞ্জ
স্যার
হয়।
অপটিক নার্ভটা ড্যামেজ হয়ে যাওয়ার জন্য ইন্ট্রাঅকুলার প্রেশারটা বেড়ে যায়।
Correct. So main important thing is intraocular pressure. So intraocular pressure if increases, then what will happen? It will exert pressure on the nerves. है nerves where? On the retina. So if it is exerting pressure on the retina, how will retina behave? What will happen to the retina?
রেটিনা প্রেশার পড়বে।
Exactly, retina will go damaged and person will go blind. So why is beta blocker used over there? Beta blocker is used over there because it decreases the secretion of aqueous humor. Okay, it reduces aqueous humor production. So if aqueous humor is reduced, production is reduced, that means intraocular pressure is getting reduced. And if intraocular pressure gets reduced, that means there will be the life of the patient will increase, the life of the eye will get increased. Understanding? So, and also migraine. Okay, in case of migraine also beta blockers can be used, because after all it will have certain effects on migraine also. Because migraine, why does migraine take place? Do you have any idea?
না স্যার।
হ্যাঁ স্যার।
Yes, sir. Okay, what is migraine? What is the purpose of beta blocker in migraine? See, it says that in prophylaxis of migraine. So definitely this is not a medication for migraine, isn't it?
হ্যাঁ
Yes, so actually what happens is there are actually many theories for migraine. Okay, honestly speaking, I'm not a neurologist, but for migraine, it is there is no such reason which has been ascertained yet. Definitely, there are a lot of working theories and different medications. There are a lot of medications which work on migraine. So different medications they work on different level. So one such theory is that when you have got very increased blood supply to your brain, okay, into your head, so blood pressure increases. So when the blood pressure increases in your cranial vessels, it exerts pressure on the surrounding nerves. And if on the surrounding nerve the pressure is exerted, then there is pain. The nerves get excited, the pain receptors get excited, and you develop migraine because of that. So this is what is migraine. Now can you understand that why beta blocker can be used? So if you are using beta blocker,
স্যার
then
আরেকবার বলবেন মাইগ্রেনটা
one such theory, one working theory out of many theories is that if blood, like imagine, I don't know how to say it. So imagine there's this blood vessel. Now if this is a blood vessel, then wow, right now another person is entering at such a beautiful moment. Okay, so Devashmita, you have only a few minutes left. Too early for the next class.
হ্যাঁ স্যার মানে ওই ভীষণ ডিস্টার্ব হচ্ছিল তো ফাইনালি এখন জয়েন হলো
Acha. So do you notice that here I am making this blood vessel, and can you see that there are a lot of nerves which are surrounding it?
হ্যাঁ স্যার
So imagine that if there is vasodilation, okay, if the vessels start to dilate, don't you think that these nerves will stretch?
হ্যাঁ স্যার হবে
So when there will be stretching of these nerves, there will be pain. So that's what happens is ki in case you do not want migraine to take place, so if you are taking this medication, so blood vessel will not dilate. है ना? So if blood vessels do not dilate, actually speaking here, non-selective beta blockers are mainly used because we need to block both beta 1 as well as beta 2. But this is a mechanism that it will
Sir,
not.
স্যার বলছি অ্যালফা 2 দিয়েও তো হবে মানে ব্লাড ভেসেলস গুলোকে তো ওরা শ্রিঙ্ক করায় মানে
Alpha receptors.
আলফা 2 দিয়ে আলফা 2 অ্যাড্রেনার্জিক প্রপার্টিস গুলো
হ্যাঁ, but again alpha 2 is going to be present on that area, na, presynaptic receptor.
ও হ্যাঁ 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 স্যার
So you cannot work that way. So we can use this either beta 1 selective blocker or mainly beta 1 as well as beta 2 non-selective.
হ্যাঁ স্যার ওকে
Okay. Okay. Now one easy way to remember is that at the end of beta blockers there is olol written, like carvedilol. So whenever there is lol, when next time somebody says in your WhatsApp lol, you should remember beta blocker. You can ask them that why are you writing lol? Do you want a beta blocker? Okay, so labetalol. So at the end, so lol for layman is laughing out loud, but for the doctors, lol means you are talking about the beta adrenergic blockers. Understood everyone this part?
হ্যাঁ স্যার
Achha.
হ্যাঁ স্যার
All right. So next we are going to talk about a very common drug, propranolol. See, again olol is coming up. So propranolol, I don't know, is there? See, can you see this photo? So this is how. So this is how it is sold in the market. So this is a government brand. So, but this is a propranolol. So in this way you can you get tablets like this. Anyways, we'll start from here. Okay. So if we, as far as the propranolol is concerned, so it is a prototype beta adrenergic antagonist because it blocks both beta 1 as well as beta 2 and biggest important thing is it has equal affinity. So normally if you are giving any drug to any such propranolol to any patient, so usual dose is once daily. Okay, that is OD. You know, OD is once daily, BD is twice daily. You have learned about prescription writing?
হ্যাঁ স্যার
Acha. So yes, so this is it, that this is going to be about the like once daily dosing. Now first action that we come across, that is the cardiovascular action. So definitely I hope you understand, it will diminish the cardiac output. So do you know what is chronotropic effect and what is inotropic effect?
স্যার ক্রোনোট্রপি তো ওই ট্যাকি আর ব্র্যাডিকার্ডিয়া, আর আয়নোট্রপি হচ্ছে তো আপনার ইম্পালস বেশি, যার ইম্পালস বেশি ইম্পালস কম, যেটা ওটাকে আয়নোট্রপি বলছে।
Okay, look, suppose this is look at that right side wala heart that I have made. So right atria, posterior lateral wall, this is the SA node, and towards the base of the right atrioventricular node, like right atrioventricular junction, here there is the AV node. Then from here there is this bundle of his, and then this is going to break down into the left bundle branch, and from the left bundle branch there will be a right bundle branch, and then from these branches there is going to be the Purkinje fiber. Do you agree?
হ্যাঁ স্যার
So this is going to be this is the picture of the heart completely. So now the thing is this, ki over here, if there is anyone who is increasing or decreasing the rate, okay, increasing or decreasing the rate, that is chronotropic. So if it is increasing, so positive chronotropic; if it is decreasing, negative chronotropic. Understood?
ও আচ্ছা, হ্যাঁ স্যার
Now, what is inotropic? Inotropic is all about contractility here. Okay, so this is inotropic. That means, suppose if there is any if there is excess of calcium, so calcium will facilitate muscle contraction, or they won't facilitate muscle contraction.
মাসেল কন্ট্রাকশন ফেসিলিটেট করছে।
Correct. Muscle contraction will be facilitated. So over here remember that if you add calcium, that means calcium can act as a positive inotropic agent.
হ্যাঁ স্যার
So over here remember that inotropic agents deal with muscle contraction. Either they will relax the muscle or they are going to contract the muscle, and chronotropic agents are going to alter the rate of the heart. Okay,
ওকে স্যার
so definitely now you are talking about beta blockers. So beta blocker, what will they do? They will have negative inotropic, negative chronotropic, because say like if they are working on the beta 1, so definitely they are going to work on the, like they will diminish all the activity. है कि नहीं?
হ্যাঁ স্যার
Yes, so you see, if you have to lower down the heart rate, then you can act on the SA node and the AV node, so both are getting depressed.
হ্যাঁ স্যার বলছি স্যার ক্রোনোট্রপি মানে হচ্ছে ইম্পালস কন্ডাকশন রেট, আর ওই এটা কি মানে কন্ট্রাকশন রেট হবে?
Contraction, huh?
ওকে স্যার বুঝেছি।
Okay, so alright, so now if you see SA node, it's a negative chronotropic agent, mane what are we expecting, bradycardia or tachycardia?
স্যার ব্র্যাডিকার্ডিয়া হওয়ার কথা।
So there is going to be bradycardia. So because of this bradycardia, like there is a contraindication to this drug. So if you think that bradycardia is harmful for the patient, so you should not give this kind of drug. So if you talk about say stress or exercise, during that time sympathetic nervous system is already activated. So if sympathetic nervous system is activated, then what will these beta blockers do? What are you expecting? That what will they do? Beta blockers?
স্যার বিটা ব্লকার্স কমার কথা, কারণ তখন তো ট্যাকিকার্ডিয়া হয় অ্যাকচুয়ালি, মানে এক্সারসাইজের সময়।
হ্যাঁ, but do you think beta blockers are going to be very much effective?
না স্যার, বেশি এফেক্টিভ হবে না, কারণ তো ওটা তো রিফ্লেক্সে করছে,
Exactly.
রিফ্লেক্সে তো পারবেই।
Of course. So beta blockers are not going to be effective. That is what is attenuated. So beta blockers are going to become attenuated. And if you see beta blockers getting attenuated, so heart rate will definitely increase. So sympathetic, if the person is taking say propranolol and the person is doing exercise, simple funda, clinical, you have to ask the person to take rest. You have to tell the person that you should not go for running or you should not go for exercise. You should not go. You are taking beta blocker medicine doesn't mean that you will be jumping around like monkeys. Okay, okay. Don't use the word monkey for the patient. That is between you and me. So, but you should advise the patient not to doing heavy exercise or stressful activity. Okay, now next thing is if we talk about oxygen consumption, this is what I was talking about at that moment. You remember heart attack wala thing. So oxygen consumption is decreased by blockade of this beta 1, and you see this is the reason for use in MI or angina. See, that is what is written over here. Here it is written for angina, but the same is the reason for this MI. So, and I hope you understand this, that they are effective in attenuating the supraventricular cardiac arrhythmia, because heart rate will be lowered, na? Beta blockers.
হ্যাঁ স্যার।
Yes. Now, over here, now this is observation that generally they are not effective against the ventricular arrhythmia. So, if it is supraventricular arrhythmia, see, do you have idea about this supraventricular SVT or VT?
না স্যার।
No. Okay, because this is a little bit of core concept of cardio. It's when you study cardio, then or when you study ECG, that time you understand. I'll just give you a brief idea. What happens here is, so then you can understand what is this arrhythmia all about. So let us suppose I have got a beautiful heart. Not that way. I have a beautiful heart on the screen. And over here, let's suppose these are the chambers, the atrial chamber, and this is the ventricular. I'm just making a schematic, very bad diagram, but just for solving the purpose right now. So what happens is, sometimes certain muscles become too much active. Normally, what do we know? Normally, we know this is or like this diagram that I have made. This is a contractile myocardium. Okay, na? There are two types of myocardium. One is a contractile myocardium, and then another one is a specialized myocardium. So when you talk about myocardium, there are these two types: contractile and specialized. Now, this is a specialized myocardium. Okay, this is a specialized myocardium. This is a specialized myocardium. This is a specialized myocardium. This is a specialized myocardium, and this is a specialized myocardium. So red color, what are they? Muscles or nerves? Whatever I have made in red color.
Muscles, sir.
Of course, very good. There are no nerves over here. Okay, it's all beautiful muscles. Now, over here, if I say that there are some contractile myocardium who actually possess the capability to become a specialized myocardium. Basically, let's say this is a pathway. This is a separate pathway through which impulse can pass. Net result, the impulse which was supposed to traverse through this pathway, now some of them they are going to traverse through this pathway also. So what happens is that there are going to be some ectopic focus. Ectopic means other than normal. So normally what was the focus? The focus normally was SA node, but now there are ectopic foci. So till now we know that from SA node it will go to AV node, then it will go to bundle of His, then it will go to bundle branches, then it will go to the Purkinje. But now we see along with that there is present another sideways pathway through which it can enter. So naturally you understand that heartbeat stimulus will depolarization waves will reach ventricle rapidly, one after the other, after the other, after the other. Here there are many deep knowledge, like information present, like circus movements and a lot of things are there. We are not going into that detail right now. When we'll discuss cardio, then I'll teach you. So further, I mean, do you understand that there will be ectopic foci developing, because of which ventricle will get stimulated too frequently, which will lead to arrhythmia?
Yes, sir.
So basically, if your focus is in the ventricle, if your focus, that ectopic focus, if your ectopic focus is in the ventricle, that is VTAC or ventricular tachycardia. But if that ectopic focus lies somewhere in the atrium, then that is SVTAC or the supraventricular tachycardia. So observation says that propranolol is not good for the ventricular arrhythmia, but it is good for the supraventricular arrhythmia. Okay, it makes sense also. Can no, because see, just now we learned that it mainly works on the SA node and AV node.
Oh, sir.
Okay, and also remember that at high doses, propranolol may also cause a membrane stabilizing effect on the heart. Okay, so but for this you have to give high dose. Okay, at therapeutic dose it doesn't work so well. You have to give very very high dose to make it to make the membrane of the heart less excitable, or membrane stabilizing effect. Okay, so that is required. So do you understand? Everybody understood the cardiovascular action of propranolol?
Yes, sir.
Yes, sir.
Okay. Now let's see what else propranolol can do. Now, peripheral vasoconstriction. See, propranolol is a non-selective blocker, not cardioselective. So it will have an effect on the blood vessel. So there was, you remember there was a beta 2 mediated vasodilation,
Yes, sir.
but right now beta is blocked. So who will cause vasodilation? So in simple language, there will be vasoconstriction. So if there is vasoconstriction, what do you think will happen with the venous return? Venous return should increase, decrease, or remain same?
Sir, increase. Sir, increase হওয়ার কথা তো।
Increase হওয়ার কথা. Okay, let's see.
তবে ভেসোডাইলেশন হলে তো ব্লাড ভেসেল মানে ভেন্স গুলো তো বড় হয়ে যাচ্ছে, তো ব্লাড মানে ফোর্স না দিলে পৌঁছাবে কি করে? এটাই বলছি।
হ্যাঁ, তো you are saying that there should be venous return should decrease or increase?
ডিক্রিজ করবে মনে হচ্ছে।
Decrease. Okay, let's see. So imagine this is your beautiful blood vessel, and then here there is present your unmole capillaries. There will be many subunits. I'm not making them, like arteries, then arteriole, then meta-arteriole, then so many things are there. I'm not going with that. So these are going to the venules. Venules are going to join, and then they're going to become the vein, like this. Now what are we learning? We are learning that there is supposed to be what? Vasoconstriction. है ना? There should be vasoconstriction. So if there is I'm so sorry. Of course. So you prevent vasodilation, so there is going to be vasoconstriction. So if there is vasoconstriction, let's suppose this area gets constricted. So Devasmita observed that if this area goes constricted like this, do you think there is good amount of blood going on to the venous side?
No, sir.
And even if the vein also gets constricted, do you think blood can pass through it?
No, sir.
Exactly. So, if the veins they are constricted, if the arteries are constricted, venous return will decrease. If venous return is decreased, then your cardiac output, what should happen to the cardiac output?
সে কার্ডিয়াক আউটপুটও কমে যাচ্ছে।
Exactly, cardiac output will decrease. So if there is, cardiac output decreased, so blood pressure will.
ডিক্রিজ করছে।
Cardiac.
স্যার বলছি একটা ভেসোডাইলেশন করছিলাম, ভেসো কনস্ট্রিকশন না স্যার।
Vasodilation.
হ্যাঁ স্যার ভেসোডাইলেশন করছিলাম না।
एक minute, there was this beta 2, if you trigger beta 2, vasoconstriction is to occur, vasodilation is to occur, beta 2 receptor. Suppose there is a blood vessel, and on this blood vessel this is beta 2.
ও না ভেসো কনস্ট্রিকশনই তো হবে মানে
হ্যাঁ।
এতে-
So if you are having beta 2 blocking effect, so beta 2 was dilation, now the blocker comes up, so can those epinephrine and all they can bind?
না স্যার
Nah, competitively it will be inhibited, and if there is any competitive inhibition, then there will be
কনস্ট্রিকশন হবে না।
yes, constriction. Okay.
হ্যাঁ স্যার বুঝেছি, হ্যাঁ।
All right. So over here there is vasoconstriction. So if there is vasoconstriction, so we learned even BP is falling. So that means periphery is not getting good amount of blood. Your periphery is not getting proper amount of vascularity. है ना?
হ্যাঁ স্যার
So imagine if a patient was already having high BP. So systolic blood pressure was high, diastolic blood pressure was also high, suppose. So total peripheral resistance, now that is increasing or that is decreasing?
স্যার ইনক্রিজ করছে টোটাল পেরিফেরাল রেজিস্ট্যান্স।
Look, blood is flowing less into the periphery. So if blood is flowing less into the periphery,
ও হ্যাঁ তাহলে ব্লাড যদি লেস পেরিফেরিতে ইয়ে করে তাহলে তো রেজিস্ট্যান্সটা ডিক্রিজই করবে।
so what will happen? Total peripheral resistance will decrease. Everybody understanding? Rest of the people.
হ্যাঁ
And rest of the people?
Yes, sir.
And rest of the people?
Yes, sir.
Acha chalo, okay. So over here what we see is that the total peripheral resistance is decreasing. Total peripheral resistance has an effect on systolic BP or diastolic BP? Rapidly.
স্যার ডায়াস্টোলিক
Diastolic BP. So do you realize that diastolic BP is getting back to normal with propranolol? Yes. So you will see that in a hypertensive patient, and even your heart is getting slower, so even systolic BP will decrease. So gradually you will see that there will be both decrease of the systolic BP as well as the diastolic BP, and hypertensive patients can get some relief. Understood?
হ্যাঁ স্যার
Yes. So basic funda is that there will be peripheral vasoconstriction. Another thing is that there will be bronchoconstriction also, because you remember epinephrine was causing bronchodilation, emergency drug.
হ্যাঁ স্যার
So now you have blocked it. So there will be a tendency that there will be the bronchial smooth muscle contraction. So if there is bronchial smooth muscle contraction, If a patient is suffering from conditions like COPD or asthma, do you think it is a good one?
না স্যার ওটা খারাপ হবে তো।
Correct. So that is why in case of asthmatic patient, in case of COPD patient, emphysema patient, this drug is contraindicated. Okay, so you cannot give this drug. So before giving this drug, see, you have to keep a check on so many things. Next thing that comes up, that is the decreased sodium retention. So if you have a low BP, because you have decreased the BP, right? So if you have got a low BP, that means more blood is going to your kidney or less is going to the kidney.
স্যার বিপি
Less.
Okay, so less blood is going to the kidney. So if less blood is going to the kidney, so we will see that the this plasma volume or the water from the body, will that get lost or it will get stored?
Stroke হবে তাহলে।
Stored hobe, right? And if it is another thing is that if if you talk about the kidney, if you remember that there is this Bowman's capsule, and then there was this proximal convolutions, then there was this Henle's loop. I hope you know this basic structure, right? So thin segment, then thick segment, and then it becomes like this, the distal convolutions. So do you know this ki there are some proteins in this DCT area where sodium ka reabsorption takes place and potassium ka secretion takes place? Do you know this?
Yes.
So if perfusion or the amount of blood in your kidney is low, that means through this pipeline the filtrate is passing rapidly or slowly?
Slowly.
Slowly. If it is passing slowly, then this absorption of sodium should be more or less?
So more.
Yes. So because the filtrate should be in contact with the protein for longer time, na? So if the filtrate is in contact with the protein for a longer period of time, so more sodium will be absorbed. Rest of the people, you're understanding?
Yes, sir.
So there will be more sodium absorption. So net result is that in the bloodstream there will be a lot of water, because water is also not going out, blood flow has decreased, GFR has decreased, so there will be a huge amount of water retention, huge amount of sodium retention. So increased sodium retention is the topic, but you should know that even there is retention of the water, that is plasma volume. Okay, so there will be sodium retention and there should be retention in plasma volume. And one thing is this, ki if this happens, then that is going to cause increased BP. Plasma volume is increasing, na, after all.
Yes, sir.
So definitely it is going to increase the BP. So that is why if you are trying to lower the BP, you should also take care of the fluid volume and sodium. So that is why these patients are given with diuretics as a combination. So you should not give just a propranolol to the patient, you should give it in combination with a diuretic. If there is diuretic, there will be high frequency of urination or low frequency of urination.
Sir, low frequency.
Okay, low frequency of this urination. Remember, diuresis means loss of water. Okay, diuresis means loss of water. So any drug which is called diuretics, what should they do?
Increase the
Yes, they increase the frequency. So along with this, some diuretic needs to be added. Okay. So even if you talk about this blocking of beta, then you remember that beta receptor could stimulate glycogenolysis, and they used to cause glucagon secretion, because it was a fight fright flight reflex na? So in your blood there should be more glucose. So there was glucagon increases the blood sugar level, and also there was increased glycogenolysis, where the stored glycogen will come up and form glucose and be present in the bloodstream. Are you aware of this fact?
Yes, sir.
So the problem here is that if you are blocking, then glycogenolysis will decrease and glucagon secretion will also decrease.
Yes, sir.
Yes. Problem here will be, if there is a patient of diabetes type 1. Do you know what is type 1 diabetes? There are how many types of diabetes? 5 or 6 in general?
Sir, type 1, type 2.
Yes, thank God you know it. Yes, there are 2 types of diabetes, type 1 and type 2. So what do you think is the difference?
স্যার একটা টাইপ 2টা তো অ্যালডোস্টেরনের জন্য, আর টাইপ 1টা তো গ্লুকাগনের জন্য।
Type 2 is because of aldosterone.
ওই তো ডায়ুরেসিসের জন্য হচ্ছে, ডায়ুরেসিসের জন্য বেশি বেরিয়ে যায়,
বেশি বেরিয়ে আসছে,
মানে গ্লুকোজটা বেরিয়ে যাচ্ছে, তো গ্লুকোজ ইউরিয়া, গ্লাইকোজ ইউরিয়া।
You think glucose passing out through urine is normal?
না স্যার।
Then look, first of all, I think I should clarify it out. You're telling it a big blunderous and dangerous thing you are telling. Okay, first let me clarify. There are 2 types of diabetes, okay? One is called as diabetes mellitus and another one is called as diabetes insipidus.
ও হ্যাঁ, ওটাই আমি গুলিয়ে ফেলছিলাম, ইনসিপিটাস আর
Like
মেডিকেল।
gulia pill disease becomes different, na? Your diabetes insipidus occurs due to deficiency not in aldosterone but deficiency in ADH, anti-diuretic hormone, that's in the pituitary. So over there, if there is any problem, then there is diabetes insipidus. But here when we are talking about glycogenolysis, glucose, that means definitely we are talking about diabetes mellitus. Mellitus has something to do with sweetness, sugary substance, not insipidus. Understood? So if we talk about diabetes mellitus, there are 2 types. One is insulin dependent and the other one is insulin independent. Like there is type 1. Type 1 is insulin dependent. Type 1 is autoimmune. Okay, what happens is that there are some autoantibodies which destroy the beta cells. So your autoantibodies, if they destroy the beta cells, then who will produce insulin? So there is no insulin in the blood. So blood sugar rises. So if there is no insulin in the blood and if the blood sugar rises, can I treat this condition by giving them insulin?
হ্যাঁ স্যার।
Yeah. So that is why it is called also known as insulin dependent diabetes mellitus. So type 1's another name is insulin dependent diabetes mellitus, and type 2 is non-insulin dependent diabetes mellitus. Now try to understand this, that if there is a patient who is insulin dependent diabetes mellitus and you are giving propranolol, that means the patient is already taking insulin. That means blood sugar level is वैसे भी low, and then you are giving propranolol, which is a beta blocker. That means glycogenolysis has decreased and glucagon secretion has also what?
গ্লুকাগন ইনক্রিজ করছে ওই ডিক্রিজ করছে।
Glucagon decrease করছে. So you see that means in your blood what is happening? The sugar level can extremely fall, isn't it?
Yes, sir.
আচ্ছা
Yes, that is why you should also notice that a very close monitoring is very much necessary in case a person is having insulin dependent this thing diabetes, type 1 diabetes. So if you are giving propranolol to them, so you have to be carefully monitoring the blood sugar level of the patient. You cannot just like that give the medicine and just leave it like that, okay?
হ্যাঁ স্যার
All right. So now there is one more action. So here we talk about the blocked action of isoproterenol. Do you remember isoproterenol activity? Epinephrine.
হ্যাঁ স্যার ওটা তো
Norepinephrine.
ওখানে আলফা 1 আলফা 2 ওখানে মানে
Yes.
সবচেয়ে বেশি ইয়ে করতো।
So I think it is quite clear here, as I have written, that all beta blockers have ability to block the actions of isoproterenol on CVS, cardiovascular system. It does not create a cardiac stimulation or reduction in mean arterial pressure and diastolic blood pressure. And in presence of beta blocker, epinephrine no longer lowers diastolic blood pressure or stimulates the heart. I hope you understand this thing. This is very common. But vasoconstrictive action, will it also affect the vasoconstrictive action?
না স্যার সেরকম
No, because that is working through alpha receptor, na vasoconstriction.
হ্যাঁ স্যার
Yes. So it is going to block the effect of epinephrine in every place other than blood vessel. Can it block norepinephrine?
না ওটাও তো আলফাই হচ্ছে।
Correct. Norepinephrine works through alpha, not through beta. So it can never work on the norepinephrine activity. It cannot, oppose the norepinephrine action. Clear, everyone?
Yes, sir.
হ্যাঁ স্যার
Cool. So next, moving on to the propranolol kinetics. So as far as the kinetics are concerned, it is completely absorbed because it is lipid soluble. So lipid soluble means it can pass through the membrane. Lipophilic, I hope you know the meaning of the word lipophilic.
হ্যাঁ স্যার
And then
Repeat করুন।
yes, so there will be a simple case, fast pass metabolism, and hence a very little amount will reach the circulation, that is 25%. These are all facts, okay? These you have to remember. VD, that is the volume of distribution. If you are giving orally, then it is 4 liters per kg. Mane, simple language, if you for those people who never attended the earlier classes, simple language is overall how much volume it is spread out. That is what I always teach. So it is spread out over 4 liters per kg. So in every kg around like 4 liters of this drug can be found, okay? So definitely it's good, it's a large volume of distribution. And since it is lipophilic, it can be soluble in the lipid, so it can also cross the blood brain barrier. Do you know this thing? Polar elements cannot cross the blood brain barrier, but since it is lipophilic, so it will cross the blood brain barrier. Propranolol is metabolized. Metabolites can be excreted in urine because propranolol is lipophilic, so it cannot get excreted through urine. Its metabolites can get excreted through urine. Clear with this?
হ্যাঁ স্যার
All right.
হ্যাঁ স্যার
Okay. So once we are done with the with this, now we talk about the therapeutic effects. So what are the therapeutic effects that we see here? So hypertension, migraine, I think I have discussed. Hypertension, I don't think I need to discuss again. Same things are written again. Migraine also I have discussed. Okay.
হ্যাঁ স্যার
So see here I have mentioned sumatriptan. So sumatriptan is a specific drug for migraine. Okay, it has nothing to do with beta blockers. The point is this, that you have to remember that it was used for prophylactic measure for migraine. not a treatment. If you are having an attack, at that time sumatriptan is the most important thing, है ना? Myocardial infarction, I have discussed this part also. Hyperthyroidism is also discussed. See, we have discussed all these things. Angina pectoris we have discussed. Check it out whether any part you are not understanding, or if you are understanding, then I'll proceed ahead. I have done a lot of mehnat and discussed all these topics to you already. This is just a gist which is written over here. Are you understanding or not?
Yes, sir.
Yes. Now moving on to the bad effects. So bad effect also we have discussed. Bronchoconstriction, asthmatic patient, COPD patient should not be given. This also I have taught you. Then if you are like, suppose your arrhythmia is a big problem. When suppose you are taking beta blocker, I am taking beta blocker, a person is taking beta blocker, suddenly you stop the beta blocker, then body won't be able to adjust, na? So immediately if the person had earlier arrhythmia, now that suddenly that arrhythmia will come back, because suddenly the blocking effect will be gone, na? All the receptors will go open. So if all the receptors get opened, or adrenergic receptors, so adrenergic stimulation will come up and there can be arrhythmia. Common sense. So what to do? Desensitization. How can you do desensitization? By making it gradual. You taper off the drug. So when you gradually and slowly, when you keep tapering the drug, so what happens is that it is more like signaling the cell, and the cell is going to reduce the receptors, and as slowly the receptors get reduced, so once you stop the beta blocker also, then there might be a lot of adrenergic molecules, but they won't get much receptors. Could I explain this, or you are confused?
না স্যার বুঝেছি।
Okay.
স্যার আবার একটু বলুন না।
Look, here what we were discussing is ki, do you suppose this is a cell. Now in this cell, situation 1, okay, this is situation 1. Situation 1 is you had these receptors 1, 2, 3, 4, 5. Here are these receptors. Now all are blocked. Now what happens is, suddenly you stop the drug and all these receptors open up. So don't you think that now epinephrine will come up and bind with all of them?
হ্যাঁ 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 স্যার।
So immediately there will be adrenergic effect, immediately there will be arrhythmia.
ও আচ্ছা।
So what do we do is, first you lower the dosage. So when you lower the dosage, so what happens is that there will be desensitization. So because why? Because see, now there will be two open receptors. Now when there will be two open receptors, and say epinephrine is working on these two only, so body will understand that this is the number of receptor that I should have. So in the next step, what will happen? Body will actually internalize these receptors and maybe leave over here 3. Understanding how it is getting balanced?
হ্যাঁ স্যার।
Yeah. So this is how you should work, like you should give the drug. You should taper off the dose over a period of time, not like suddenly stop it. Okay. Okay, now here comes up this point, is sexual impairment. Now remember, last class also I think we discussed that sexual function, that is primarily if we talk about the ejaculation, so that ejaculation that occurs through alpha or beta.
স্যার ইজাকুলেশনটা তো সিম্প্যাথেটিক।
Yeah, but that is okay, that's a very basic thing, but it works through alpha receptor or beta receptor. So beta, it is primarily through alpha reception, okay, alpha activation. So ideally beta blockers should not have any effect on the ejaculation or internal bladder sphincter action. Okay, but there are some ambiguity, but for you don't need to bother about it. Okay.
Okay, sir.
Huh. Now this metabolic disturbance. So blood sugar wala thing to we have already discussed, correct?
Yes, sir.
Yes. Now another thing that you should remember, that is patients administered non-selective beta blockers have increased LDL, triglyceride, and reduced HDL. Mane for blood, in simple language, cholesterol level will be increasing. LDL is the bad lipid, na? Low density lipoprotein, so that is increasing. Triglycerides, not good for health, increasing. Good for health, high density lipoprotein, that is decreasing. Okay, so the lipid profile will go very bad. All right.
Yes, sir.
Okay, sir.
Yes.
Now the important part is that is the last line, that the serum lipid profile in dyslipidemia patient improves with use of beta 1 blocker. Okay, metoprolol is a beta 1 blocker, so metoprolol can improve the serum lipid profile. Okay, so that's the exceptional case for metoprolol. That's exception, you have to remember that. Clear?
Yes, sir.
Okay. Now, as far as the CNS action, this is very simple. You have to remember that there will be, it is lowering down everything, na? So lethargy, fatigue, depression, weakness, these things can happen. Short-term memory loss can happen. Okay, just remembering this way that everything is actually deteriorating. Okay, and then we can have the drug interactions. In drug interaction, you have to remember cimetidine. So what is cimetidine? Cimetidine is more like, have you heard of ranitidine, Rantac?
Yes, sir.
So cimetidine is belongs to the same category. So ranitidine, cimetidine, they all belong to the same category. And also, have you heard of this thing, the next drug, that is fluoxetine?
না স্যার, ফ্লুইড শুনিনি।
Acha, it is basically an antidepressant. Okay, fluoxetine, paroxetine. Okay, ritonavir. Have you heard of ritonavir?
হ্যাঁ স্যার, রিটোনাভিরটা শুনেছি।
It is a antiretroviral drug. Okay, so it is used for the HIV treatment and all. So these drugs inhibit the metabolism of propranolol. Okay, so if they inhibit the metabolism, that means effect will prolong or effect will shorten.
স্যার শর্টেন হবে।
Shorten হবে. Look, if metabolism is inhibited, that means
না,
the
তাহলে তো প্রলং হচ্ছে মেটাবলিজম।
Prolong
okay, so the drug effect will prolong. Acha, and if we talk about barbiturate is again central nervous system drug. Phenytoin is used for epilepsy. Okay, and what about rifampin? Rifampin is used for tuberculosis. So rifampin is anti-tubercular drug. Phenytoin is anti-epileptic drug. Barbiturates are of course the sedatives or hypnotics. Okay, so these drugs, they actually stimulate. So if they stimulate, so effect will be decreased. They stimulate metabolism. Metabolism is stimulated mane faster metabolism. Faster metabolism mane duration of action is getting slow.
হ্যাঁ স্যার।
Okay, so there will be decreased effect. But if you are giving, say, propranolol, if you are giving cimetidine, fluoxetine, paroxetine, ritonavir, then anti-hypertensive effect will be increasing because their action will become longer. Okay,
হ্যাঁ স্যার।
Yes, sir.
all right. So this is the story of propranolol. This is the most important drug. When we will go in the cardiac portion, you will see that people they mainly use propranolol. Okay. So after this comes up timolol, nadolol, and now the non-selective beta antagonist. So we'll discuss these non-selective ones in the next class. Okay.
Okay, sir.